Today on Vital Insights,
you're able to treat them with more conservative approaches rather than needing hospitalization. We know that hospitals are the worst place for the elderly. Patients go to the hospital, they never end up coming back healthier than when they left.
Welcome to an episode of Vital Insights, a podcast series focused on thought leaders and healthcare providers who are working to transform the way we care for patients, now and in the future.
The actualization of patient-centric care requires a deep understanding of patient pain points, sometimes literal and sometimes figurative. Our guest today, Dr. Zachary has spent the past 2 decades with the oldest among us, earning a wealth of knowledge on how to care for older adults and enable better aging in place solutions. Welcome to Vital Insights, Dr. Pallas.
Thank you.
So can you, just for sake of kind of framing the conversation, can you give me a little background on your medical practice as well as your experience in the field of geriatrics?
Sure. So I've been a geriatrician for the past 20 years. And basically, over the course of the past 20 years since I completed my fellowship, what really drove me to go into geriatrics was recognizing that patients are often treated in the hospital, and that so much of the care that they get in the hospital really could be rendered in the nursing home or in other lower care level facilities. And basically, I always felt driven to try to improve the quality of care and improve what we do, identifying the systems of how we care for patients and making them better. And over the course of the past 20 years as a geriatrician, and as a medical director at the Hebrew Home, I've had a lot of experience in terms of being able to treat patients outside of the hospital, being able to help improve outcomes and improve care by identifying medical conditions, identifying healthcare issues at an earlier stage. And by being able to treat conditions earlier, you're able to treat them with more conservative approaches rather than needing hospitalization. We know that hospitals are the worst place for the elderly. Patients go to the hospital, they never end up coming back healthier than when they left. They often end up acquiring bed sores, acquiring hospital-acquired infections. They become more confused. There are issues with medication reconciliation that often occurs when patients go out to the hospital. The medications that they went out on, the medications that they came back in on. There are often a lot of discrepancies, which can often lead to polypharmacy and many other issues. So sending patients out to the hospital is fraught with many adverse outcomes for geriatric patients. So our goal is really to try to identify conditions earlier and ability to treat patients in place, and having continuous monitoring and having approaches that new innovative approaches to care can often help produce much better outcomes.
That's fantastic. And you did a great job of summarizing for me some of the unmet needs that you found among your own patient population. You've had experience now utilizing the early sense technology. Can you tell me in broad strokes about how that's been able to impact those patient outcomes within your patients?
Sure. So in my years in the nursing home, a lot of our time was spent trying to identify new methodologies and algorithms for being able to reduce hospitalizations. And very often, we were very successful with those innovations. We put together a blood transfusion program, and by being able to do things as outpatient, we were totally able to avoid the hospitalization experience. But there were certain areas that we identified that even with more surveillance, even with more observation, we were still finding that patients were going out to the hospital to a higher extent than we wanted them to. Those 2 areas, I would say, would be number 1, respiratory infections, and number 2, sepsis. And invariably what we found was that somehow people didn't necessarily notice that the patient was having a cough one day, and then within a day or so, that cough would become a bronchitis, which could become a pneumonia and progress to sepsis. And often we were picking up these conditions when they were already quite sick. So trying to move that window up and trying to be able to address those issues at an earlier point in the trajectory of illness would be very, very beneficial in terms of identifying patients who are ill and treating them sooner. And it was really that group of patients who were developing sepsis, that group of patients who were developing pneumonias, where picking that up earlier could really, really impact on the course of treatment. So, for me, that was an area that we were looking at and trying to identify ways that we could reach that goal and identify patients who were sick sooner. And this was about the year 2011 or so, 2012, when we learned about the early sense technology. And the more we learned about it, the more we recognized that this really meets the unmet goal. I mean, this is an incredible technological innovation that brought into the nursing home and brought into, an assisted living facility, brought into a situation, brought into an environment, I should say, where an elderly person can be monitored more regularly. The system can notify us and it can observe and identify when there are deviations from the patient's norms. So say the patient is starting to have increased respirations, starting to breathe a little bit faster, or starting to become a little bit tachycardic, their heart rate starts to go up. Those are points where we can intervene now, and those are points that a nurse just on basic observation may not notice. It isn't that, it may not be as obvious, it may be more subtle. Some of those changes, or especially early on, could be subtle when a person is starting to breathe faster, their pulse rate's going up, but the system's able to identify that.
Right. Absolutely. So one of the things you just touched on that I love that you've made a leap to is that idea of continuous monitoring versus kind of intermittent spot checking. Can you talk a little bit about how those two are different within your populations and also how you see them working together?
Sure. So obviously, when a nurse notices that there's a change, the first thing she's going to do is she's going to go and collect a set of vitals. And that's very important because obviously the clinician needs that information. Vital signs are a very actionable data point. So without those vital signs, it's very hard for the clinician to act. So when the nurse calls the physician on call or the physician who's off site and provides the physician or the nurse practitioner with that information, that's very actionable information. But that's really one point in time. Of course, when we're able to have continuous monitoring in place, the nurse is able to provide more information. And the more information that we have, the more information that we can use in clinical decision-making. So if the nurse tells us that the patient's pulse is 110 right now, but the patient always runs around 100 or so, that may not be as concerning as if the nurse would tell us that the system that is continuously monitoring the patient has noted that her baseline pulse is always around 70 to 80, but in the last 2 hours or so, it's been consistently over 100. That tells us that something's going on. It may not necessarily be that the patient is developing an illness and becoming acutely ill. It may mean other things too. I mean, elevated pulse has a significant differential diagnosis that's not limited just to infection. So for example, a patient could be experiencing pain and associated with experiencing pain, it's very common for an individual to have an elevated pulse rate. Many of our chronically ill patients, many of our cognitively impaired patients may not be able to articulate that they're experiencing pain, but that information that we're getting that the patient is having elevated pulse makes us look further to see what's going on and ask the questions that helps us come to the proper diagnosis.
Absolutely. Taking that one step further, in terms of thinking about compliance and how that's of impact within your population of people, does a solution like this that's kind of a little bit set it and forget it or very non-intrusive? Is it helpful for that patient population? And if so, how do you feel it impacts them the most?
So absolutely. I mean, I think nobody likes to, especially if individuals living in assisted living or in a skilled nursing facility, many people don't like to see all the wires and
Right.
it's very limiting for them. Having something that is completely, out of sight, out of mind, that's underneath the bed, it's almost like it's not there. And in fact, it's not there for patients. They might not even notice that it's there. As such, it can be less disturbing for them and just makes them feel like they're in more of a home-like environment.
And that is critical.
Yes.
Because nobody, as you said earlier on, nobody heals in a hospital. We need to be at home to do that.
Absolutely.
Are there any patient stories that you often go to kind of illustrate the key points you've made thus far? Obviously, please don't share names or anything like that. But is there an anecdotal story you share about a patient to highlight how remote patient monitoring can be really effective?
Sure, absolutely. I mean, one that always comes to mind that I always share with our clinical team, and it was a real win for our clinical team. It was a patient who was on our short-term rehab unit who was relatively stable. He was downstairs in the physical therapy gym working out, came back upstairs. The nurse put him to bed. And he was essentially fine. I mean, he was comfortable, he was calm, he was asymptomatic, so to speak. About an hour or so later, the system alerted the physician on the floor that there was an increased pulse rate associated with a markedly increased respiratory rate. She promptly evaluated the patient and found him, quite short of breath. He was diaphoretic, he was sweating, he was visibly in distress. He hadn't cognitively impaired. He didn't have the insight to press his call bell and ask for assistance. And upon further evaluation, her clinical decision was to send the patient out to the hospital. When the patient got to the hospital, at that point, he was already quite short of breath and rapidly becoming unstable. Developed a cardiac arrest and was resuscitated and determined to have a pulmonary embolism. Pulmonary embolism was treated in the hospital, and remarkably, about a week later, he came back to us to continue his rehab stay. I have no doubt in my mind that without the system in place, he would have just, peacefully probably gone into cardiac arrest in his bed, and no one would have known of any of this, and it would have had a very significantly different outcome. So I often speak to cases like that, where having that information can help us act and actually save lives.
That's incredible. I mean, I actually got chills when you were telling that story. I'm sure you've told it so many times, it's kind of old hat, but those are always the really most impactful stories to me is the people who are here because of the technology, right? Who are still with us because of the technology. Shifting gears a little bit, if you imagine kind of a virtual care world, so extending the same technology into patients' homes, what do you feel are kind of the principal roadblocks to get to that future from both a provider standpoint and maybe even a patient standpoint?
So I would say from several components. I mean, you need to have a structure in place where somebody is at the other end monitoring that information. So we're collecting a lot of data on patients, but you can't have a physician or necessarily a nurse practitioner sitting and monitoring everybody all the time. So having the type of a system where when it identifies significant changes, to be able to have a system in place where there's somebody who's on call, who would get those alerts, review the data, and then forward it on to that individual's clinician. I think that's an important aspect to have in place. I think very often one of my concerns is alarm fatigue, where if the system is alerting too frequently, that the end user, the physician or the nurse practitioner, might tend to discount the alerts. So that it's very important, in the future that all this technology, that it's vetted from the perspective that it's giving real-time alerts that are that are basically filtered so that there's less alarm fatigue and there's less background noise, so that the actual alerts, when they come through, can be considered more reliable, especially when this is taken out, on a larger scale in the community, where individuals throughout the course of their day, or throughout the course of their night. I mean, you don't necessarily have a lot of you can't have like one physician, every physician having all of his patients on the monitoring system. You would need, I would say, probably somebody, as I said, an on-call individual who would collect those alerts or interpret those alerts, analyze those alerts at the first level, and then forward those on to the physician. So probably like a mid-level practitioner, somebody who has knowledge of the patients, who, when they receive the alerts, could kind of filter them out as well, so that the alerts that are getting to the physicians are the most salient alerts with the most important changes.
Absolutely. I completely agree. And lastly, is just kind of a quick wrap-up question. We've talked for years about shortage of healthcare resources, doctors, physicians, nurses, et cetera. And of course, COVID and the pandemic only exacerbated that. Are you seeing evidence of that on the front lines where you work? And if so, do you feel that technology actually has the capability to alleviate that challenge?
So there's no doubt about it. I think, what we've seen during the course of the pandemic is, fewer physicians that are willing to go into the nursing home, more physicians that are looking to just really practice medicine through telemedicine and practice medicine virtually. So you lose that hands-on contact on the patient when you do that. And having the more data you have, as I said earlier, the more data you have, the more you're able to make more informed decisions on the patient. So even though we may have less physicians, less nurse practitioners, less individuals going into the nursing home, or making house calls, and conversely as well, you have patients who are more averse to coming into the office to be seen,
right,
are looking for other means of being able to be evaluated because they don't want to expose themselves to unnecessary infection. Having this type of technology helps just give the clinician more information that they can use, in assessing and evaluating patients.
That's wonderful to hear, because that's why we're in this too. So it was absolutely wonderful to speak with you this morning. Thank you so much for joining us. Do you have any last thoughts you want to share with our listeners?
No, I mean, my pleasure. I'm glad I've been able to give some insights into what we do. And just to add a little bit more to what I had mentioned earlier in terms of pain management, we really see tremendous benefits with a system like this in terms of helping patients who are in pain, who can't articulate that they're in pain, particularly in the cognitively impaired area. And another point to touch on that we didn't mention was falls prevention. Having a system that can help us identify individuals who are at increased risk of getting out of bed and increased bed activity can help us in terms of mitigating falls, helping reduce the incidence of bed ulcers if patients are not moving in bed and getting alerts that the patient hasn't turned. So there are many, many opportunities that a remote monitoring system can offer us. It was a pleasure to share some of my insights with you today.
Thank you so much. Take good care.